Welcome, everyone. We're back after a bit of a winter break. I'd like to welcome all of our returning viewers back to the session and also welcome all the new people to these. We've recently expanded our invitation list to a handful more divisions across the province. So welcome to everybody. And without further ado, I hand it over to David, who's going to teach us all about diabetes.
Wow, I don't know all about, that's a broad order. Okay, well, thank you so much, Anna, for the presentation. Thank you to everybody who's here tonight. I was a little worried if anyone was going to actually show up tonight, given that we've had this break. So really excited to see you folks here. For those of you who don't know me, my name is David Brown. I'm a miscellaneous officer here with Div 176, kind of involved in training, kind of involved in a little bit of everything. I'm a primary care paramedic and emergency medical dispatcher with the Provincial Ambulance Service in BC, and most importantly for tonight's talk, a type 1 diabetic. So just give me a quick moment here. I'm going to share my screen up and we'll get the presentation started here. All right. So I've always wanted to go on a beautiful vacation to the islets of Langerhans. I think that sounds like a beautiful place. So what are we talking about tonight? We're going to cover the pancreas, because that's the most important organ we're going to be just dealing with today. We're going to talk a little bit about insulin and natural insulin. We're going to discuss what diabetes is, some different types of diabetes, some common complications and side effects of diabetes. We'll cover synthetic insulin, other common medications. We'll talk about glucose testing, and then we'll finish off talking about diabetic emergencies. The general assumption here is that a lot of folks here have done an MFR class, have done like a fairly standard diabetes presentation where you talk about sugar and basic stuff like that. So we're going to go over those, but this is a little more focused about like some of the background behind diabetes and some of the ongoing lifestyle stuff related to diabetes, more than it is about the specific emergency situations and scenarios, especially because those tend to be more hands-on, but we will cover those as well. So just some standard disclaimers that we're including with everything. This presentation isn't updated to discuss any of the current COVID-19 treatment or practice guidelines. If you're a part of a division or an organization that's still out on duties right now, you should refer to your division's particular practice guidelines and updates that way. And two, we're going to talk about some things that are not in the scope of practice. I'm going to show you how to do some of them on myself. Not training, it's not an endorsement. Please don't watch this video and then pretend that you know how to do it because you saw me do it once. So starting off, we've got the pancreas. So the pancreas is located right where you can see it in the photo. It sits right in the upper abdomen, just above the stomach and the upper intestines. And it's part of the digestive system. So it's one of its two functions is that it actually secretes what's called pancreatic juice, which contains a large amount of sodium bicarbonate, or functionally baking soda. And it secretes it into the small intestine. So just as all the stomach contents are leaving out the bottom, and it secretes it in there to neutralize the acid of the stomach so that it can be traveled through the rest of the intestinal system. And the other thing it does is it regulates blood sugar. And that's what we're going to do most of our focusing on tonight. So we can see this is a slide of a section of the pancreas. And so all of these darker pink cells are the cells that are responsible for excreting the pancreatic juice. And then these smaller, paler sections here are the islets of Langerhans. And those are the small areas of the pancreas that are responsible for regulating blood sugar. So these islets are made up of alpha and beta cells. So the alpha cells secrete a hormone called glucagon, and glucagon works throughout the body to convert stored sugar called glycogen back into usable glucose. So glucose is a very simple molecule, and it's got these just very small strands. And so what the body does is to store it. It takes those teeny tiny molecules of glucose and wraps them into these long chains that are much more compact and efficient for the body to store, called glycogen. And so the glucagon signals and causes the body to convert those glycogen stores back to glucose, which can be used much more easily. And beta cells, which we're a little more interested in tonight, are responsible for secretion of a hormone called insulin, and that helps lower the blood sugar. So insulin, essentially, increases the uptake of glucose and fats into muscle cells and allows them to process them better. So the insulin reaches into the cells and promotes the whole cell to essentially act as a key, opening up the door into the cell for the glucose to go inside and be processed and broken down. It also increases some of the metabolic activity within the cells. So it's a signal to the cells that they're getting more sugars, more energy, and that type of thing coming. So they're going to start doing a little more work. So if they've been maybe holding off on breaking down some organelles, breaking down or secreting some waste, it's also a signal that they can start picking up that activity to get ready to go. So that's about as deep as we're going to touch in on the pancreas itself. We'll talk in more about cells and that kind of thing. But are there any questions specific to the pancreas and that anatomy there? I don't have the chat box open here. Okay, well, we'll keep moving on. If you think of questions as we're going here, you just put them right in the chat box and we'll come back to them. So our next big step is, what is diabetes? So the word diabetes itself is actually incredibly broad, and all it talks about is any of many disorders that are characterized by increased urine production. That's all diabetes is. So we're going to talk about a particular type of diabetes, diabetes mellitus. It's also just worth mentioning the other most common form of diabetes, which is still extremely rare, called diabetes insipidus. Patients that have diabetes insipidus will directly identify it as insipidus because it's not the disease many people think of when they hear the word diabetes. And diabetes insipidus as well is a very broad catch-all term, essentially for any disorder that involves huge increases in fluid intake and huge increases in urination and fluid output. It can come from a huge range of different causes, but has nothing to do with blood sugars. And that's really all we're going to talk about there. So diabetes mellitus is our real key topic tonight. So diabetes is a metabolic disorder, and essentially the key problem is that your blood sugars increase because the body isn't able to process carbohydrates and glucose molecules effectively. So all forms of diabetes mellitus are associated, when they're untreated, with increased thirst, frequent urination, increased appetite, and all of those are processes in which the body's trying to excrete excess sugar through increased thirst by wanting to take in more water to help flush out the fluids, that frequent urination, as well as the increased appetite, just trying to get any balance in because the body isn't able to effectively process carbohydrates and receive nutrients from a lot of food. So your body's needing to take in much more food to be able to get the equivalent number of nutrients it needs. So in Canada, there's about 3.4 million people, or about 9% of the population, that has some form of diabetes. And type 1 diabetes only makes up about 10% of those cases. So type 1 diabetes, as much as it's potentially the better known or better recognized form of diabetes, is actually fairly uncommon as diabetics go. So in the past, it's been referred to as juvenile diabetes or insulin-dependent diabetes. And both of those are less accurate names for it now. So that's why type 1 is really settled in as the accepted name among medical circles. It was thought that type 1 diabetes was only diagnosed in children. And as someone who was diagnosed at the age of 25, I can tell you that's not always the case. And similarly, while type 1 diabetes is always insulin dependent, more and more patients with type 2 diabetes are also beginning to be on insulin therapy. And so because of that, identifying type 1 as insulin dependent diabetes on its own isn't a particularly accurate name. So type 1 diabetes, almost all of the time, and there's a few very rare exceptions, is an autoimmune disease. And so the body creates an antibody that's called the GAD65, and those go into the pancreas and attack the beta cells. And essentially, as it destroys the beta cells in the pancreas, it destroys the cells in the body that are capable of producing insulin, and it causes you to produce less and less insulin. And when you don't have insulin, you don't have the keys and the tools required to, you don't have the keys and the tools required to break down that glucose. So you start to see those sugar levels elevating. So type 1 diabetes typically is diagnosed between about the age of 2 and 8. And that's not saying it's sitting undiagnosed in someone all the way up to age 8, but it typically, the disease itself sets in between age 2 and age 8. But it can set in at any time. There's, it's not uncommon to hear of people in their 20s and 30s being diagnosed with type 1. It does happen. I've read case reports of people all the way up to the age of 60 being diagnosed with it with a relatively recent onset. The exact cause of it is still unclear. Like, we understand the mechanism is these JD65 antibodies being produced, but it's not completely clear, especially in children, what causes those antibodies specifically to be produced. One of the current hypotheses is that it's related to antibodies in the gastrointestinal tract. So while I don't have celiac disease, I still test positive for some of the antibodies associated with celiac disease. And that's not uncommon for a lot of diabetics. And so that's believed to be a large part of it. There is a small link between family history. So if one of your parents has type 1 diabetic, you have about a 6% chance of getting type 1. About 5% of one of your siblings has it. Identical twins, it's only 50% though, which suggests some kind of genetic link, but it's obviously not 100% genes. Otherwise, in older patients, a lot of the time it's associated with a viral trigger. So a lot of the time when people have some type of viral infection, the body's already producing antibodies to try and fight that viral infection. And so for whatever reason, and we're still not totally clear, the body will then also produce some of these JD antibodies that attack the beta cells in the pancreas. So type 1 diabetes will always require insulin therapy, is the very short version. Exercise and carbohydrate management both help to reduce the overall need for insulin in the body, but type 1 diabetics will universally be taking insulin. There is no cure for type 1. One of the ongoing jokes you hear is that it's been 5 years away for the past 30 years. There's some experimental treatments. I'm part of a clinical study right now for relatively newly diagnosed type 1 diabetics who still have some beta cell function left, taking some immunosuppressant drugs that they're trying to see if those can regulate the JD antibodies to try and prevent further damage to the pancreas. And there are also experimental procedures around pancreas transplants and specifically only transplanting beta cells into an otherwise unhealthy pancreas. The issue with those is that they come with significant side effects, both from the fact that a transplant is a major surgery and the fact that most of the time anti-rejection medications and the other regimens and restrictions placed on someone who's had a transplant of any organ typically seem to affect people's quality of life greater than the side effects purely of having diabetes and the management required of having diabetes. And so almost every pancreas transplant that's been performed is being performed on somebody who is already receiving a transplant for whatever reason. So we'll talk a little bit later. It's not uncommon later in life for diabetic patients to end up with a kidney transplant, for example. And so if someone was receiving the kidney transplant, then they might also be considered for a simultaneous pancreas transplant, because at that point, they're already going on to these anti-rejection medications and all the side effects associated with it. So type 2 diabetes is a very different disease. And there's some discussion that linking the two diseases together with very similar names does a disservice to both of them. But it is caused, essentially, instead of having a decreased amount of insulin in the body, it's caused by having an increased resistance to the same amount of insulin in your body. So previously, it's been referred to as non-insulin dependent diabetes or adult onset diabetes. As I mentioned earlier, more and more type 2 diabetics are starting to be using insulin therapy. And similarly, it is becoming diagnosed more and more in younger children. I believe in the States, it's something like 1 in 10 children under 16 have type 2 diabetes already, potentially even higher than that. I don't have the exact number in front of me. Type 2 diabetes is closely linked with obesity and inactivity. People who have an elevated body mass index and live very sedentary lives are at a much greater risk of developing type 2 diabetes. A family history of type 2 diabetes is also a strong predictor for its development. Older age typically becomes a higher predictor for its development, although that's becoming less and less common. And hypertension, so high blood pressure, which generally speaking is also a measure of overall health, although obviously there are people that experience just isolated hypertension that don't necessarily have other health issues that way. So we can see here the case counts of type 2 diabetes are rising rapidly. Almost, I believe, almost 1,000% difference in diagnoses between 1985 and 2015. But we can see there's a very clear distinction in this chart that's on the right there. It's a very clear link between type 2 diabetes and obesity, and the numbers are rising largely in parallel. When somebody becomes obese, it causes generally higher levels of blood glucose, and that's caused both by the fact that they have more tissue, and as well, they typically is associated with an unhealthier diet. And so the pancreas has to work that much harder to produce enough insulin to get insulin to all the tissues in the body and produce a larger volume. As well, the unhealthy diet typically requires larger amounts of insulin, and so the pancreas becomes essentially fatigued. And so because as well, there's more insulin circulating throughout the body, and the body becomes normalized to those higher levels. Eventually, the body just becomes somewhat immune to the insulin, and so they become less sensitive to it. A lot of the time, especially when it's caught early, type 2 diabetes can be managed through diet, so going to lower carbohydrate diets. Exercise. Exercise generally increases a person's insulin sensitivity, increases overall health, and also helps promote weight loss. And weight loss makes a big difference, especially in the very obese. Like gastric surgery, bypass surgery, and other weight loss surgeries have been shown to significantly decrease the severity of and potentially help reverse the effects of type 2 diabetes. It can be managed very effectively this way. Many type 2 diabetic patients will also take certain medications that increase their sensitivity to insulin, and we'll talk about those a little bit later. But a lot of the time when people either aren't able or aren't willing to make those lifestyle changes, or simply they've had it for long enough that it's been just an entrenched part of their body system, they will also begin to take some insulin therapy as a supplement to these other adjuncts. It's worth noting that for type 2, while the symptoms can be well managed and controlled through these processes, it's not considered curable. Like somebody with type 2 diabetes will always have type 2 diabetes. But many people can effectively get to the point that they either don't have to take any medication and can manage it through their lifestyle choices, or can get to the point where they don't appear to have it. But if they started to put on weight or started to eat a less healthy diet, then they would start to see those effects come back immediately. Gestational diabetes is just another one that's worth mentioning. It's not something I have a huge subject matter knowledge in, so don't ask complicated questions about it, pretty please. But it occurs only in pregnant women, and it is related, essentially, it's very similar to type 1 diabetes, where the body produces less insulin or inadequate insulin for the body's needs during pregnancy. It typically does resolve itself after childbirth in the month or two afterwards. It is a strong indicator for an increased risk of type 2 diabetes developing later in life. And I believe most of the time when someone is diagnosed with gestational diabetes, it doesn't resolve after the pregnancy. It's almost always considered to be type 2 diabetes. It occurs relatively uncommonly in 2 to 10% of pregnancies, but people with the risk factors for type 2 diabetes are more likely to develop it. Typically, again, it's managed similarly to type 2 diabetes, largely through diet and medication, although about 10% of the cases of gestational diabetes do end up requiring insulin. So when they're trying to differentiate between type 1 and type 2, a lot of things can provide good indicators. So somebody with a high body mass index, so someone who's obese, somebody who has a poorly controlled diet, who has a strong history of type 2 diabetes, when they show up to the hospital with their blood sugar wildly out of control, it's probably going to be type 2. Similarly, someone who is athletic, lean, doesn't have any kind of history, and shows up to the emergency with their blood sugar completely out of control, it's likely to be type 1. But there's two key ways of determining, and both of these are lab results. So the C-peptide tests for the amount of natural insulin being produced by the body. So when your body produces insulin, first it produces a molecule called protoinsulin, and that is an insulin molecule wrapped up inside of a C-peptide chain. And as your body splits those two apart to be able to create functional insulin, those C-peptide chains just go floating around loosely. And so those only occur in naturally produced insulin. Synthetic insulin doesn't have C-peptide chains. So that's how they can test for a patient, for basically how much insulin your body's naturally producing. And then similarly, you can see there's the GAD antibodies. So they can test for the GAD65 antibody that, they can test for the GAD antibody that attacks the beta cells in the pancreas. Just give me one moment here. And then the A1C level is the third lab that just provides indication of where somebody's blood sugar is. So, sorry, Anna's just messaging me that there might be an issue with my screen. Can you just put it in the chat if you can see like a slide that says type 1 versus type 2? It has lab results in the bottom there.
That's a delayed message.
Oh, okay.
You're all good.
Okay, great. Sorry, I just saw that now. So you can see this is my most recent C-peptide there. And so I'm making on my own about half of the lower end of the reference range. So I am still making a certain amount of insulin on my own. My body's still producing some. But over time, that number slowly decreases. And with that, the demand in my body for synthetic insulin will slowly increase. So questions about diabetes, what is it, types of diabetes, that kind of thing?
So David, there was one question in the chat. The question is, does diabetes mellitus cause obesity?
Great question. The short answer is no. So we'll talk a little bit about like symptoms of somebody that's having these hyperglycemic episodes, but most of the time, one of the parts of a diabetes diagnosis includes sudden unexpected weight loss. As your body is either producing less insulin or unable or becoming insulin resistant through type 1 or type 2, your body's less effectively able to extract the nutrients, and like protein, for example, breaks down into carbohydrates into your body and requires insulin to break down, similarly to fats. And so eventually your body can't get the nutrients and effective tools it needs from your diet through insulin. And so part of that is it will start breaking down fats to provide its own energy because it can't get it from the glucose into the body. So typically diabetes on its own as a disease is associated with some weight loss. A lot of the time as people transition onto insulin therapy and are learning to manage their blood sugars, a lot of the time it can be associated with a small amount of weight gain there, partially just because the body's been dehydrated, malnourished, and short on a lot of essential things for a while. And so as it gets back onto insulin and better able, the body overreacts a little bit and starts packing on for the next hibernation period that's coming up. But for type 2 diabetes in particular, the obesity and weight gain is typically the cause of the diabetes as opposed to being the other way around. I hope that makes sense. Any other questions coming up about there? Great, well, we'll move forward then. So common complications of diabetes. And so this isn't going to be the emergencies that we're likely to see at the first aid tent at whatever event. This is much more just trying to build an understanding of what people with diabetes experience and what people with diabetes are dealing with over the course of their lives. So one of the key ones that is going to be an overriding theme through the rest of the section is vascular disease. So especially as people are having these prolonged periods of hyperglycemia or high blood sugar, it causes a hardening of the blood vessels. And the very small capillaries and very small blood vessels, especially peripherally, so into the fingers, the toes, the hands, the ears, the eyes, anywhere there's the very, very small blood vessels, are most susceptible to that because the walls are already so thin. So even a small amount of hardening causes a big issue. So one of the places it presents is in the eyes. So diabetic retinopathy, which is a very fun word to say, is a hardening of this very small blood vessels that run especially through the retina, but through the whole eyeball. So it causes decreased blood flow to parts of the eye. You do need blood flow to your eyes to be able to see effectively. So it'll slowly cause a decrease in overall vision, especially centrally. People get central graying, central darkness. And then as it progresses, and essentially the blood vessels just become so stiff that they start to burst, you actually people will start to bleed into their eyeball, both externally and internally. So externally, people will experience, you'll just see just the very large broken blood vessels into people's eyes. But then internally, you'll start to get the visual obstructions from like the very small blood clots floating around in your eyes. And over time, the increased volume inside of the vitreous humor and inside of the eyeball actually can cause the eyeball to swell and change the shape of the eye, change the shape of the retina, and affect the vision as well. Similarly, prolonged periods of hyperglycemia, so high blood sugar, cause the whole eye to swell, which similarly changes the vision of the eye and changes the ability to focus and can cause you near farsighted. When I was diagnosed, the whole reason I got checked out in the first place was I sat down at work one day to dispatch and suddenly realized I couldn't actually read the screen right in front of my face that I was able to read 3 days ago. People with diabetes are at greatly increased risk of other common eye complications, so cataracts, glaucoma, retinal detachments. And it's not uncommon actually for people to get like a routine eye exam just because they think they need glasses, that type of thing, and that be the triggering event for them finding out that they have diabetes, particularly in folks with who are developing type 2. I'm very, one of the upsides of my diagnosis is I do get free eye exams under MSP, and especially because of these complications, a lot of the time recognizing them early while there isn't a particular treatment, recognizing these complications starting to set in and onset early can either be just a triggering event for people to understand that they really need to start gaining a better control of their blood sugar, or it can be just a sign that these are progressing and need to be watched more closely. Having a lower average blood sugar, keeping your blood sugar in a safe range, is a really key part of keeping these complications and worsenings under control and trying to prevent them from getting worse. Peripheral vascular disease, so vascular disease in the peripheries, especially into the feet. It typically occurs first in the feet, and because there's poor circulation to the feet. But any kind of injury, when there is reduced blood flow, there's reduced ability for the body to heal, and there's reduced ability for the body to work their way through. Similarly, increased levels of sugar in the blood. Sugar is something that bacteria, viruses, any kind of infection really love. And so it makes significantly higher rates of infection. I think uncontrolled diabetics have something like a 200% greater likelihood of getting an infected wound than someone who's non-diabetic. Similarly, because you have what's called neuropathy, and we'll touch that a little bit more, but a lack of feeling, you're not going to feel the sore that's developing on your foot. You're not going to feel the blister that's getting infected. And so that's why a lot of the time, almost every family doctor appointment that a diabetic will have will start with a quick check on the feet, just making sure that there's nothing developing there that needs caught up. And it's becoming less common as more technology and ability to manage blood sugars go. But especially in older diabetics and folks who have poorly controlled diabetes, lower limb amputations are not uncommon, as infections, especially in the toes and feet, just become so severe that an amputation is the only way to effectively manage them. And along those lines, we've got neuropathy. So damaged nerves, basically when there's nerves also need blood flow and nutrients to be able to work and do their job. And so the nerves become damaged and either decrease or lose sensation entirely. And again, because the extremities have the smallest blood vessels that are feeding to them, it's most pronounced there. So a lot of the time, and especially to the feet, so a lot of the time diabetics will start to have reduced sensation into fingertips and into the feet and toes. Cardiovascular disease is a huge issue for people with diabetes. So again, because of the greater increased risk of vascular disease in general, people are at much higher risk of cardiac events such as heart attacks and strokes because of the hardening and thickening of the blood vessels in and around the heart and the brain. And similarly, because diabetic patients tend towards that neuropathy and a lack of sensation, a lot of the time heart attack presentations and MI presentations are already a little atypical with their presentation, particularly in women. But it's been shown over and over again that more people present atypically than the classic crushing left-sided central chest pain. And so diabetics are a particularly high risk group for that, both because it's a much higher risk of coronary artery disease, as well as having a much higher likelihood of presenting atypically. And this would be a really big take home for this one is any patient that's known to be diabetic, that you have even an inkling that they might be experiencing a cardiac event. So any kind of pain, even if it's just an ache into the shoulder, an ache into the back that just doesn't make sense, anything that's just tipping your ear that it might be a cardiac problem, they need to get that followed up with at a higher level of care and could easily justify a 911 call. Almost any paramedic you talk to will talk about the diabetic that presented to them a little wonky and something was wrong and it ended up being a major event there. So really keep a close eye on that. Our last complication we're going to talk about here is kidney disease. So into the kidneys, where you get all your blood filtered out through the nephrons. It's the microscopic, tiny, some of the smallest blood vessels in the body lead into those nephrons where the blood is filtered. And as those harden and become more brittle, blood eventually can't flow through them into the nephrons. And so your body's just not effectively able to filter blood nearly as much. And so you'll start to get what's essentially kidney disease. So you're not able to filter that. And a lot of people with diabetes do end up either with kidney transplants, as mentioned earlier, or on renal dialysis. And so having a port placed and essentially having to go in to get a machine do the dialysis for you. So questions about complications, anything like that?
All right, there were a couple questions that came up. The first one was, can blood alcohol content affect a blood glucose reading?
Short answer is no. And we'll talk a little bit more about glucometers a little bit later, but the short version is no. It's very separate things. Blood alcohol in the blood can affect your blood glucose, but it doesn't specifically affect the reading.
And the next question was, is there a correlation between diabetic patients and an increased risk to shock?
And again, this is where I think we're going to separate out into type 1 and type 2 diabetes because they are very different conditions. Specifically for type 1 diabetes, I would say generally no. Like the blood glucose is an extra vital sign that you need to monitor, but there isn't a particular correlate, like there isn't anything in there that's going to make somebody more susceptible to hypovolemia, neurological shock. Like it doesn't affect your blood filtration or circulation volumes very much at all. With patients with type 2 diabetes, again, the condition itself isn't going to make a big difference in somebody going into shock or not going into shock. But it's worth keeping in mind that type 2 diabetes is generally associated with a relatively unhealthy lifestyle and a generally poorer health overall. And I want to put a very clear asterisk on here that there are many people out there for whom a diagnosis of type 2 diabetes was a reminder or an indicator or a reason to get in shape. And while they have type 2 diabetes and will make sure you're aware of it, they are extremely healthy, fit, have a great diet. And I don't want to be lumping everybody together. So is it specifically an increased risk of shock because of diabetes? But especially patients with type 2 diabetes, you should be keeping a thought for that because they do have a higher risk of other medical complications that way. I hope that answers. Great. Any other questions?
Oh, there's one more that just popped up. Andrew asks, are there other signs and symptoms of hypoglycemia that could be mixed up for something else while on duty?
Oh, a topical question. I'm going to park that, Andrew. We're going to talk a little bit more about signs, symptoms, and that kind of thing a little bit later. But that's a great point. I'll make sure we touch on that. So moving forward, we're next going to talk about synthetic insulin and other medications. And this is where we get into a little bit of show and tell with all the bags of stuff I carry with me. So talk about insulin, and from now on, when I'm talking about insulin, I'm talking about synthetic insulin and not the naturally produced insulin in your body. So it was actually invented in Canada. This is a little piece of information that I really love. It was discovered by Frederick Banting and Charles Best in Toronto, who were awarded Canada's first ever Nobel Prize for medicine for their discovery. So they basically went completely out on a limb on this, recognizing that they kind of thought the pancreas had something to do with all these kids and all these issues with diabetes. And so what they started doing was first they took dogs and removed their pancreas and basically just started sucking out the juice from the pancreas. I'm not joking here. And first they injected it into themselves to make sure it was safe. And then at that time, like there was no treatment, there was nothing that could be done for diabetes. And so as children developed type 1 diabetes at that point, essentially they just slowly slipped into comas, and really anywhere between days and weeks later, they died. And so there was this ward of children all just slowly dying of diabetes. And they just went through and gave each of them a small dose of their synthetic insulin that they've just tested out. And all these children started to wake up. Like, it's a pretty magical thing. So at that point, their original insulin was extracted from dogs. They pretty quickly started going to slaughterhouses and getting bovine and porcine insulin. And up in as late as 2006, insulin was still being removed from deceased cows and pigs. Canada officially stopped allowing animal insulin in 2006. And it was relatively uncommon by the late 90s as we got better at creating synthetic insulin. So now all the insulin that someone is going to take in Canada does come from fully synthetic. And it's actually interesting, we use bacteria, and I won't pretend to understand the process, but there is a whole process where they take bacteria, grow it in things, and it turns into insulin. So when people are talking about insulin, there's typically two types that we discuss. There's fast acting and long acting. So the fast acting has a relatively quick onset time. So it begins working in the body within about 20 to 30 minutes of being injected. And that's used to offset food and carbohydrates. So it's typically given with each meal. And then there's a long acting. And so what that's doing is replacing the insulin that's involved in just the background metabolic processes in the body. So it has a similar or slightly faster onset time, but it stays in the body for 20 to 40 hours, depending on the insulin that you're taking. And so it's just designed to keep the blood sugar stable between meals and just work through a lot of those normal processes through the body. Synthetic insulin comes in a lot of names. This is a quick handful of the ones that are most common in Canada. The only one I'll point out on here that's slightly interesting is Alfreza, which is actually an inhaled insulin. It's what's called an ultra fast acting insulin. And so it's just a small, essentially a puffer. And it's not very common in Canada at all, but I think it's something that's quite interesting that way. So dosing. So we give insulin in, I'm sure there's an explanation behind it, but I couldn't find a great answer. A relatively arbitrary dose called a unit. So a healthy body that has a functioning pancreas, unlike mine, typically works through about 50 units of naturally produced insulin a day. But you have a store in the pancreas of about 200 units. Typically, insulin comes in 100 units per milliliter, but it does also come in a higher concentrations. It's called U200 and U500. And this is really just interest stuff. This isn't something you need to know or understand. So dosing of the basal insulin in particular depends entirely on the individual. So somebody who has no pancreas function whatsoever, no beta cells left, is going to be taking a lot more insulin than somebody who, like me, I've still got some working there. So I would take less basal insulin because all the insulin I have right now is just going directly to dealing with those basal functions. And there's just not enough to do any of the short-acting work. So the fast-acting insulin, the dosing is also dependent, but typically a person takes somewhere in the range of 1 unit of insulin for every 15 grams of carbohydrates that you take in. And so I've put on the right here, this is a chart that was handed to me by the dietitian when I first got diagnosed. And this just gives you a rough idea of what 15 grams of carbs actually looks like. So my typical meals, I'll take anywhere between 2 to 6 units of fast-acting insulin. But then if I'm eating something that has a whole whackload of carbs, I've given up to 10 units, although that's been a pretty wild meal, going all out at KFC for that. So I'll move past there. Insulin is given almost always, except for the inhaled stuff, which is uncommon. It's given as an injection into the subcutaneous layer of fat. So for people who aren't as familiar with the skin, you've got the outer layer, the epidermis. Then you've got the subcutaneous layer, which is the layer of fat that sits between your skin and the muscle, and then the muscle underneath it. And so the insulin goes into the subcutaneous tissue because it allows it to spread out and release over a little bit longer period of time. Because there isn't as much blood flow to the subcutaneous fat there, it just takes a little longer to reach into the body. And so instead of slamming all the insulin into your body at once, like if you injected it into the muscle where there's much more blood flow, it provides a little bit of a gentler curve of the insulin there. It can be injected by needles, which is what we can see in the picture here, pens, which we'll talk about in just a second, or a pump. And basal insulin is given either once or twice per day, depending on how you choose to do it, and that's the long-acting. In fact, fast-acting is typically given at least once per meal, and a lot of the time people will take 1 to 2 correction doses throughout the day, depending how accurately they track their blood sugars. So insulin pens, they are still a method of giving an injection, but they are just a little more discreet. You're not pulling out a needle and waving around there. And they also provide slightly more accurate dosing. So this is one of my pens here. You can see it looks a bit like a regular pen. And so at the bottom, I don't know how well you can see this. At the bottom here, you have just a click wheel that provides you dosing. So all you have to do is just spin it to the number of units you want to give. And then if you push the plunger all the way in, it will give exactly that many units. I'm just gonna put that back to 0 before I do something dumb. And so this is another pen that I have, and this one's all primed to go. So you can see there is this plunger that reaches up through here that slowly pushes the medication out. And then this is just the needle. And so all that happens is it just threads onto the end. You remove the cap, and then you've got a needle ready to go. You might even see a beautiful little droplet of liquid gold there. So those are insulin pens. They are, I think, the most common form of how people administer insulin in Canada. The needles are becoming less and less common, partly because of the stigma associated with them, and also partly just because of the convenience, accuracy of pens. Insulin pumps are magic, and I can't wait to get one once I have benefits again. But they provide a steady stream of a very small amount of fast-acting insulin over the course of a full day, instead of taking a separate injection of basal insulin. So I, for example, if somebody takes 24 units of basal insulin, it will just slowly give you an insulin per a unit of fast-acting insulin per hour to replicate that. And so it allows for greater control, because some people find they have larger insulin needs at night or during the day or at different times. So you have finer control and you can adjust it there. And they also allow you to provide boluses, so the fast-acting insulin. And a lot of the time, like my fast-acting pen only goes in, I'll get it the right way up here. You can see it's the special junior pen. So it only goes in half-unit increments, whereas the most of the insulin pumps on the market now provide insulin in as detailed as 0.01 units. So you can provide much more detail there. And they provide the insulin through a cannula that sits in the subcutaneous tissue, and it lasts 2 to 3 days typically before you have to change the site. These are just some examples of different insulin pumps. So this one on the that you can see with the woman pointing to is called an Omnipod. It doesn't have tubing. The whole thing sits on your stomach. Everything else just is a separate device that's attached by a tube to the infusion site. When you're dealing with patients with insulin pumps, I would be extremely, extremely cautious of messing with the insulin pump unless you know exactly what you're doing. The amount of insulin that most insulin pumps are delivering at any given moment is not going to be enough to really change your treatment that much. But you can do significant harm either by somehow accidentally providing insulin or messing with the pump. So at the MFR level, when you're building your treatment plan, I would not consider playing with adjusting or trying to remove the pump. And especially, never try to remove the insulin pump from somebody's body. If you're dealing with the point that you have some reason to believe that this is a malfunctioning insulin pump that's giving way more insulin than needed, that's well beyond what you should be trying to manage on your own as an MFR, and you should be looking for a higher level of care that way. Other medications include metformin. So metformin's anti-hyperglycemic medication, mostly seen in type 2 diabetics, although some people like myself who still have some remaining pancreas function do also take it. And the big thing it does is it increases your insulin sensitivity. So basically it means that each of the little natural insulins that I'm producing has the best effect that it can. And similarly for type 2 diabetics, it increases their insulin sensitivity to give their body the best chance of not needing supplemental insulin to begin with. Glucagon is another medication that comes up, and it's becoming less and less common, but it's an emergency injectable medication for patients having hypoglycemic or low blood sugar episodes. And it basically, in your liver, there is a small store of glycogen, so those very well stored, compact, dense glucose or dense sugar molecules. And what it does is it just tells your liver, okay, all hands on deck. And it promotes the liver dumping those glycogen stores into glucose and into the body. It causes significant hormonal changes throughout the body and really affects them pretty roughly. It is not in the MFR scope. Please don't give it to anybody. And in general, I would be very cautious with giving it. About the only time we get, like, it's in the primary care paramedic scope. The only time it's really used is either for whatever reason we can't get an intravenous line, or it's at the point that somebody is altered and so combative or violent and aggressive that it's not safe for us to try to attempt an intravenous line. Questions about medication? I see Carly has a great explanation of how the medication is done. And I'm so glad. One of the things I love about St. John Ambulance, there's always someone smarter than you in the room. Oh, this is my other prop I was going to show you. This is a demo version of the Omnipod. So this is actually a demonstration of a tiny little insulin pump. So this is the one that sticks to your body. So it just sticks to anywhere that has subcutaneous fat and injects a small cannula into your body there. These ones are teeny tiny. They're actually disposable, so they're replaced every 3 days. You just peel it off and stick a whole new one in there. This is an interesting little thing. All right, we're almost there, so bear with me. We're getting into the fun stuff, in my opinion. So some of the technology. So glucometers. These are the standard tool for checking blood sugar. They are the most accurate. That's not taking the blood to a lab and getting it done. It's what most type 2 diabetics use. It's what all emergency services use. So the picture up on the screen is a bit of an old, kind of gnarly, ugly one. This guy here is my glucometer. It is sleek, it is beautiful, just like me, and actually connects by Bluetooth to my phone. It's very cool. So the process of taking a blood sugar, I'm going to do it for you guys here just for a little point of entertainment. Don't judge my sugar, whatever it ends up being. I just ate. So you're going to take a test strip. So these are single use. You can see it's like these guys here. And you plug it into the machine. It's going to take a second to warm up. While you do that, you take your Lancet. This is a big reusable one that's specific to me. The ambulance service or emergency services uses individually disposable ones. And then prick your finger and you get a little drop of blood. I don't know how well you can see that there. And then basically you use your test strip to suck up a tiny amount of the blood into there. And it's going to think for a moment. 3, 2, 1. And there we go. So it's 7.2, which is a perfectly normal number. Oh, 5.7, because I can't read backwards. Perfectly normal number that I'm not at all concerned about. And so insulin-dependent diabetics who don't have any other way of checking their blood sugar, check their sugars typically by a finger stick at least 4 times a day. Non-insulin dependent diabetics, so people with type 2 not taking insulin, typically only check their sugars once to twice a day just to make sure that their overall pattern is keeping them in a healthy range. Continuous glucose monitors, and this is the cool stuff. So you can see mine here. So these are, you can see this very small wire poking out on the end here. That actually lives in your skin for anywhere from 10 to 14 days. It uses wizardry of some sort to measure the glucose in the interstitial fluid in your body. And so there's in place for anywhere from 10 to 14 days. And they're absolute magic, largely because they provide a reading every 5 minutes. So instead of just having 4 data points, you can actually see the trend. And so this graph at the bottom is my day yesterday. So you can start to see moving through the day, there's the dips, the rises, but you can look and actually understand where your blood sugars are going, understand the effects of food, understand the effects of your medication. They're really incredible, and a key thing, I'm just going to do my tiny piece of advocacy here. They're currently not covered by MSP in Canada or in BC. And so unless you have private health insurance, they cost almost $300 a month. They're extremely expensive, but they're a really important tool. And there's something that advocacy work is being done to try and get people, or to get them covered under MSP for people with diabetes. So if you see a petition, you see stuff going around it, please consider supporting it. It really makes a big difference. So technology questions.
There was one from Carly that just came up. Carly writes, I was once told that touching the inserted end of the strips can cause false readings. Have you heard of this?
Yeah, so working with glucometers is partially art, partially science. And like any vital sign, you have to take it in context. So obviously when you're, and this is not an MFR scope, this is not something I'm training you to do. But when you are taking a blood sugar, you need to make sure that you are thoroughly cleaning the site, either with an alcohol swab, making sure there's nothing on there. You need to handle the strips carefully. I haven't heard specifically that, so I haven't heard anything specific to the touching a particular part of the strip, but you do need to use common sense and work carefully. You obviously don't want to dip your strip in maple syrup. You don't want it to be dirty or contaminated. So you want to handle it gently. I haven't heard specific to what you're talking about there, though. Andrew's question, is there a risk of infection with the continuous monitoring device being in? Yes, there is. And so part of the thing is that it takes some careful setup and careful preparation. You make sure it's clean, then you clean it with an alcohol swab, and you do have to monitor the site carefully. But it's like anything, and the same with the insulin pump infusion sites that live on your body. Those are also a part of it. yeah, Larry's point about there's lots of different brands of the continuous glucose monitors. Some are more expensive than others. There's lots of different options and ways to do it. Most private healthcare plans do cover some proportion of continuous glucose monitors, but a lot of the time people who don't have benefit plans and third-party extended benefits are also the people that aren't in a position to pay out of pocket for the equipment they need. Yeah, other questions about technology? All right, we're almost there. We're into the fun stuff. Diabetic emergencies. So we're going to talk first broadly about just defining a couple of emergencies, and then we're going to talk about treatment afterwards, because the treatment's the fastest slide in the whole presentation. So hypoglycemia, simply low blood sugar. Hypo, low, glycemia, or sugar, emia is blood. So it's going to be anytime you have altered bodily function caused by a low blood glucose or low blood sugar. Most of the time it's defined as a blood glucose of 3 millimoles per liter or less. But as with everything, your diabetes may vary. And this is a bit of a case of treating the patient, not the machine. If you have a patient whose blood glucose is 3.1, but they're loopy, confused, diaphoretic, that's a pretty good sign. You can't rule out, oh, well, the sugar's 3.1. It can't be hypoglycemia. It has to be something else. Typically, a normal range for blood sugar is anywhere between 4 and 9 millimoles per liter. But again, everybody's personal range is different that way. Early stages of it are going to be just diaphoresis, weakness, nausea, confusion. And a lot of the time, as Andrew, I think, was leading into a little bit, it can present a lot like intoxication. There's a reason, one of the key things for us at the ambulance service, if we're considering releasing somebody to the sobering center, is that we take a blood sugar. And unfortunately, there are numerous cases around the world of people dying in the drunk tank because they were having a hyperglycemic or diabetic emergency rather than just being intoxicated. And either police or emergency medical services didn't check it and didn't assess that. So certainly with the ambulance service, and I would suggest if it's part of your scope of practice, any patient with an altered mental status should get a blood sugar check. And any patient with altered mental status, a diabetic emergency should be an important part of your differential, and not writing somebody off as simply being intoxicated, or they're just drunk, or they're just high, because that can lead to really poor outcomes going forward. The brain needs glucose to function. And so just as the available levels of glucose decrease and decrease, the brain has less and less to run on. And people will start to get loopy, out of confused, disoriented, and eventually become unconscious and unresponsive. And the same prolonged periods of hypoglycemia, either somebody can be so unconscious that they're not able to maintain their own airway, and essentially they choke to death, or simply somebody just not having glucose to their brain for long enough can cause long-lasting or irreversible brain damage. So hyperglycemia is the opposite, but also very similar. So it's altered bodily function caused by an elevated glucose. There isn't a specific glucose level or reading that you need to have to be a diagnosis of hyperglycemia. Everybody's diabetes will vary. Everybody will present differently. It's typically very similar symptoms to hypoglycemia. So you get the confusion, people become obtunded, disoriented, poor balance, weak, diaphoretic. The only other big difference you'll start to see is like either a fruity or a metallic acetone breath. And that's coming from as the body's basically just trying to use any process possible to remove glucose and sugars from the body. One of the things they do is starting to breathe it out through respiratory acidosis. They are difficult to differentiate, but as we're going to talk about in a minute, differentiating them doesn't make a big difference. So the extremes of hyperglycemia, one of them is diabetic ketoacidosis, or DKA. And so this is one of the most common presentations or ways people discover that they have diabetes, in particular the type 1, is they'll present to the hospital feeling just acutely unwell and end up with that diagnosis of DKA. So basically, as the body gets higher and higher sugar and less insulin available, the body just isn't able to use glucose to fuel the body. And because the body needs fuel, it starts breaking down your fat reserves into ketones. And it's basically tiny units of fat energy that don't require insulin to process and gain energy from. These ketones are acidic and start to lower the body's pH, causing what's called acidosis, or the whole body becoming acidic. It causes increase in altered mental status, increase in confusion, all the way up to what's called a diabetic ketoacidosis coma. It is a life-threatening emergency. It's extremely serious. It typically requires ICU care. This person will end up on an infusion of insulin and very close monitoring, because that acidosis can cause really awful effects on all the organs throughout the body. So very careful managing for any kind of organ dysfunction. So signs and symptoms are fairly similar to a lot of the other ones. The big one we're going to add here is something called Kussmaul respirations. They're very deep, regular breaths, and it's kind of difficult to describe, but it's a very particular symptom that you can start to recognize as you see it more and more again. And that's just the same, the body trying to blow off glucose through respiration. You've got that fruity or acetone breath, and typically they'll have a glucose somewhere in the range of 22 to 44. But again, just because somebody's 1 point outside of their blood, out of that goal on one side or the other, doesn't mean it's not DKA. The other type of extreme hyperglycemia is hyperosmolar hyperglycemic non-ketonic state, or HUNC. There isn't really a good way to pronounce it, but everyone I've heard to either just calls it HHS or HUNC. So this is when you're getting a significant hyperglycemia, but you're not seeing the ketone production. And so this is where it's most common in type 2 diabetes. So a lot of the time you'll see people who are either discovering they have type 2 diabetes or have type 2 diabetes already. They're having some kind of infection, metabolic issue, whatever it is, that's causing them to decrease their fluid intake. And so they're not able to output sugars in their regular ways. And this is where you'll see the blood sugars go absolutely through the roof, because the body isn't able to self-limit in any way. And so that's where you'll see sugars in the 60 to 80 millimoles per liter range. And I'm not aware of a portable glucometer that can read that high. I think almost all the ones I've seen over 30 just read like HI, saying, nope, too high, I don't know. But that's going to be a laboratory confirmed value. Otherwise, there's no ketones produced. That's the biggest separation there. But it's got the very similar symptoms to DKA, but they won't present with the acetone or fruity breath. So our second to last section here, all we have left to talk about is the treatment. But are there any questions about like the medical side of some of these hyperglycemic or hypoglycemic emergencies? Great, we'll move forward. I'm glad I'm covering everything in perfect levels of detail. So in your assessment, first off, as part of your rapid body survey, and so I'll back up half a second, this whole assessment is really going to be focused around dealing with an undifferentiated altered level of consciousness, or a patient who's known to be a diabetic with an altered level of consciousness. So as part of your just a rapid body survey, which you really should be performing with anybody that's having some kind of altered mental status, part of it, make sure you're just keeping in mind, indications of diabetes. So the obvious ones, like stuff like medical alerts or tattoos, but also keep in mind, if you see something like this sticking out of somebody's arm, that's a pretty good indication that it's probably diabetes. There are a few other things, but they're not particularly common. The same, if you see a pump or a little little pager or Palm Pilot attached by tubing to somebody's stomach, that's a pretty good indicator that they may be diabetic. And so keep that in there. Neurologic status. When you're assessing your patient before you're doing any kind of treatment, make sure you get a really good GCS and take the time, flip over your PCR for the reference if you need. Take the time to get a really detailed, accurate one, because that's going to be a key part of how you know if your treatment's working or not. Detailed vital signs are also going to help detect your response to treatment. And it's also going to give you just indicators of, potential other causes of an altered level of consciousness, just to keep in mind. Just because somebody has diabetes does not mean it absolutely must be a diabetic emergency. People with diabetes do overdose, they do have strokes, they do have all of these other causes. So it's just worth keeping those in mind. Vital signs, if it's within your scope of practice, I would say any altered level of consciousness patient should be getting a blood glucose done. If it's not in your scope of practice, they're known to be diabetic and there's a family member there, I don't think you're going to be wrong with asking a family member to take a blood glucose on them. Obviously, you don't want to be making your whole treatment plan and diagnosis about this. You should be, again, escalating to a higher level of care, but it helps inform your overall practice picture in this case. With the continuous glucose monitor, so mine pushes to my phone and shows it there. I don't know how well you can see, but on my watch here, this bottom number is actually my glucose reading. So it's 6.6 according to my watch, all that type of thing. But the issue is it measures the interstitial fluid, and it takes a while. There's about a 5-minute delay between blood reaching your veins and capillaries and actually making it into the interstitial fluid. So especially for someone whose sugar might be dropping rapidly or might be increasing rapidly, that delay could make a big difference. And so I wouldn't, especially if you're dealing with an acute emergency like this, I wouldn't necessarily rely on somebody's continuous glucose monitor readings, even if a family member can, has their phone and can look at the monitor that way. So treatments, what are we actually going to do? So I want to, if there's one single thing you take away from this presentation, let it be this: do not put anything in the mouth of an unconscious patient. Like airways are unaccepted, but do not put glucose, do not put Coke, do not put anything that is liquid in the mouth of an unconscious patient. Do not put anything in the mouth of an unconscious patient. Please, there are courses and programs out there that teach this, and it's terrifying. There's a huge risk of aspiration, choking, inhalation, really significant consequences to these. If you have an unconscious patient, you should already have been calling 911, and you should be focusing on providing high quality airway protection. Your ABCs are always going to follow for any treatment. Just like you can deal with an overdose with a good airway positioning and a good BVM technique, in the time it's going to take an ambulance to get to wherever you are, you can deal with this patient by positioning them appropriately to potentially deal with vomiting and protecting their airway well. If someone is truly unconscious, do not put anything into their mouth. And I'm sorry if it feels like I'm harping on this, but this is a huge issue that I've seen across the country with these. So what are we actually going to do when we're talking about these patients that are lowered, that are altered, they're loopy, they're confused, they're out of it, but they're not unconscious? At the MFR level, without taking a blood glucose, we functionally can't differentiate between high blood sugars and low blood sugars. So what we're going to do is throw some glucose at it and see what happens. It's extremely scientific. But the big thing to keep in mind is if somebody's sugar is very low at 2.5, one packet of glucogel is going to raise anybody's sugars on average about 2.5 millimoles per liter. Not a huge jump, but enough to make a difference. So if someone's sugar is already low at 2.5, we're going to double their sugar. We're going to make a big difference in that. But if someone's sugar is way high at 25 and we give them a packet of glucogel, we're only raising their sugar 10%. They're going to go to the hospital anyway at that point. It doesn't make a huge difference. It's not going to cause more harm on the high end, but it has this possibility to make a big difference on the low end. So anybody that you either know is diabetic because they're wearing their medical alert bracelet, grandma's there, you're saying, oh yeah, he's diabetic, we're going to give glucose empirically, and you're going to set yourself up for success. So if this person's lying down, sit them up, make sure they're not laying on their back, make sure they're in a position that they can even lean forward a little bit, support their airway, make sure they're not about to breathe it in or choke or cough it down. Any altered level of consciousness patient, you should be seriously considering an early activation of higher levels of care. So I would suggest anytime you have a patient, as soon as you determine that their GCS is not 15, you should be calling 911 while you do the rest of your assessment. Patients who that empirical glucose you provide doesn't fix them pretty quickly, within about 15 minutes, that's automatically going to be an ambulance ride. That's going to suggest that they're in a hyperglycemic state or they have high blood sugar and they need to go to the hospital. And I would be very cautious of a family member saying, oh, we'll throw them in the car and drive them up. I would strongly suggest that that needs to be an ambulance ride to the hospital. Just to get it out of the way so it's said, if for whatever reason, even if the patient's saying, oh, my sugar's super high, if they can't give themselves their own insulin to correct that high, they still need to be going to the hospital because they are greatly impaired if they're at the point they can't inject their own insulin. And it's a key differentiator for diabetic emergencies, whether or not somebody's able to fix it themselves. So like for me, I drive on a commercial license to drive the ambulance. And so if I have a hypoglycemic episode, a period of low blood sugar, where I can't fix it myself. So even if I can't recognize it, I can't get the packaging for my orange juice open, I can't unzip my backpack to get my glucose tablets out, like I'm so impaired that I can't do that, my commercial license gets pulled for 3 months. And the same on the high end. So if you get to the point, someone gets to the point where they're not able to intervene for themselves, that's a key differentiation in how serious this is. And so even like trying to assist someone with their insulin is also wildly out of your scope of practice. And if someone's so impaired that they can't manage it on their own, I would be very cautious of their ability to also give themselves the correct dose, manage everything appropriately, all that kind of thing. We're into the last couple slides, I promise, we're almost there. So if your glucose does fix their altered mental status, great, let's figure out what happened. So that's where you want to start working on a history. Like it happened to me yesterday night. I took enough insulin to eat my dinner and a piece of cheesecake afterwards. And I kind of forgot about the cheesecake afterwards. And I started to dip super low and I ate the cheesecake and I was fine. But if I hadn't done that and someone had to pour sugar into me, if I can clearly explain why, there's a clear cause and effect as to what happened, I would still, as a healthcare provider, encourage someone to seek a higher level of care. We're not a particularly acute level of care. We're not providing a ton of information. I would still encourage someone. But if you have a clear plan, it's not the end of the world. If someone has had a hypoglycemic episode that doesn't have a clear cause, that's a real cause for concern. And I would strongly, strongly encourage them to either follow up very soon with their family doctor or endocrinologist, or consider going to the emergency department, either with a family member or by ambulance. Unexplained hypo or hyperglycemic episodes are very concerning because it typically indicates something significant has changed in a person's diabetes. At higher levels of care, so paramedics across the province will be providing like intravenous glucose for someone who's experiencing hypoglycemia or low blood sugars. So paramedics across the province can take patients' blood sugars with a glucometer. And so when somebody's sugars are low, we can provide them glucose intravenously to get them back up to a more normal blood sugar, and then get some food and snacks on board to keep them leveled out. Higher levels of care for patients who are experiencing high blood sugars. Typically in the hospital, they'll be getting intravenous fluids to try and dilute out the blood sugars, as well as insulin in hospital to try and lower the blood sugars as well that way. And anybody presenting with acute hyperglycemia, so if someone's at the point of having such a high blood sugar that they can't intervene and fix it themselves, or anybody who's received glucagon will typically spend at least a night in the ICU just because they need to be monitored very, very closely. So that's everything I have to present there. I see one question here. If you have a final question, this is a great time to fire them into the chat box. They can be pretty much anything remotely or vaguely diabetes related. I'm happy to answer them all. While we're just waiting for people to put those in, I'll put a couple quick plugs in here. So as Anna mentioned at the beginning, we do these almost every Monday night. I believe Anna's going to talk about the next few weeks because they're a little different. We record all of these on YouTube. I'm about the lowest common denominator as far as these presentations go. Much smarter and more experienced people present a lot more of these. And we have an incredible back catalog of all of these previous talks. And so if you see this one and you want to learn more about some of these other deep dives into topics, please check out our YouTube channel. And you can email Anna for the link to that. Otherwise, these do happen almost every other Monday night. We do have social media. We're a little quiet on it right now, but especially as the world is slowly inching back towards normal, we're going to be posting more. You can see the types of duties and work we're doing. So jump back to the questions slide. I see one question here. Does type 1 significantly raise your risk of a heart attack or stroke? And yes, it does. This is one thing that's going to be common to both forms of diabetes, is because you get that vascular disease, so the hardening and narrowing of blood vessels and arteries throughout the body. Essentially, when there's less room through the blood vessels for that blood to flow, there's going to be less blood making it to the brain and heart, but also much higher risk of a blockage into those blood vessels. Other questions about anything else?
All right. So, oh, there's another question. I'll stop what I was going to say and let you answer it.
Oh boy, sorry, I just horribly navigated and got myself lost there. How many carbs are in the glucogel? Oh, great question, Andrew. There are 22 grams of carbohydrates in the glucogel. A typical correction dose. So like if I'm starting to dip low, I will eat and most diabetics will eat about 15 grams of carbs. And that typically will raise someone's blood sugar up by about 2 millimoles per liter. Some other good substitutes, if you don't have the glucogel available, is going to be half a can of regular soda. Coke is particularly preferred because it's very fast acting. One juice box, like an orange juice box, half a Cliff Bar. There's a lot of good options. Really, you're looking for things that are lower in fat. Fat takes longer for the body to break down into usable carbohydrates, and so you want the fairly simple sugars that the body can break down quickly. But anything in the 15 to 25 grams of carbohydrates range will do. Yeah, peanut butter, jam. Yeah, jam and orange juice are great options. Peanut butter is actually relatively low in carbohydrates and high in fat. And so it's a good one for people who are dipping a little bit lower, because one of the things it also does is help extend the release of those other two. So it helps make it so you're not going to get a wild spike from the fast acting carbs that you've given. And so it helps, especially as you're just getting a little low, a little snacky, maybe a little weak, a little shaky. It helps slowly bring you back into the range without the wild spike. When we're dealing with someone that's to the point of like a truly altered mental status where like we as healthcare providers are intervening, I would err on the side of letting their blood sugar go a little too high by giving erring more on the side of fast acting than something like peanut butter. And peanut butter is also just a great snack in general. There's a question here. Diabetes is stated to be at a higher risk for more serious COVID-19 reactions. So it's a bit of a double-sided issue. The big thing is it's kind of going back to, in general, type 1 diabetes on its own is not considered to be a higher risk for COVID-19 or side effects of COVID-19. Type 2 diabetes is, and that's largely because type 2 diabetes is associated with more comorbidities. So again, because it's associated with poor health, obesity, and a lot of the other issues that on their own pull in diabetes, on their own will make any kind of infectious disease process work. When somebody has an infection, because your body's working that much harder, typically it does make sugars much harder and more difficult to control, but that's very manageable. There's potentially a higher rate or a higher risk of needing hospitalized just to get help managing those blood sugars. But the disease of diabetes itself isn't necessarily going to cause a greater risk of complications or ongoing issues from COVID or any other infectious disease. A lot of, like Canada right now isn't at the point of doing it, but a lot of states where they're defining medical conditions as being one of the criteria for the vaccine, type 2 diabetics are being included in priority groups, whereas type 1 diabetics aren't, largely because of that contrast. Other questions coming in there? Thanks, everyone. I appreciate the kind comments. If other questions do come up, you can always get in touch with Anna and she'll pass them on to me. I'm happy to answer questions by email, anything like that, if you do have questions coming along, or even just questions you're not necessarily wanting to have discussed out in the open public like this. I kind of feel like I have a little bit of a unique perspective, both as someone that works in healthcare and somebody that has this. And so I'm really happy to discuss this more in private if there's anything you want to do that way. And similarly, as we're moving out of COVID and online training one of these decades, oh, Carla's bringing in the tough questions. I'm always happy to, if there's other divisions that want to have this presentation virtually, direct your divisions, it's something I'm happy to do. Carly's swinging in talking about type 3 diabetes. There are a few other types of diabetes that I kind of refrain from mentioning. You'll see people referring to type 3, type 1.5, and these are, or LADA, and these are different types of diabetes. One of the things we're really learning now is not everything fits quite as tidily into type 1 and type 2. And so there's some of these other sub-definitions that are being used to better differentiate other patients that do have different needs beyond the typical structures of type 1 and type 2. So if somebody is identifying themselves to you as having type 3, type 1.5 LADA, they're going to be someone who's very educated about that particular type of the disease, and they're going to be someone that's very educated about their own needs for treatment of whatever's happening there. But with any of those patients, when they're presenting in an emergency state, so an altered level of consciousness, not able to help themselves, not able to effectively communicate with you, you're not going to be providing them different treatment than you would anybody else that way.
All right. As the questions slow down, I'll just jump in here. Thanks so much, David, for sharing with us. I think it's one of the first times we've had the opportunity of having this lecture presented by someone who's living this life and fairly new to this life. So that was a great perspective to share across the province. So thanks for doing that.
You know, that's where I get my insulin pen wand out. Insipidus. Mellitus.